therapist, and I've been working with Thompson for probably 12 or 13 years now. And my role is in associate health. I don't work in rehab services. I don't take care of any residents in-house. I don't do any inter outpatient therapy at this point. I'm here on Tuesdays each week to try to keep well workers well. My assumption right now is that you're all healthy enough to be here. I want to send you home as healthy as when you got here. Okay? Fatigue is one thing. We generally will fall into that during the course of our workday. But what we're going to go over in the next hour is how do we assess somebody's mobility status? What are the things that we can be looking at to make sure that we keep our safety and the residents' safety first and foremost? Okay? When do we make a decision to go to a sit-stand lift? When is a gait belt required? When do we want to use a total lift? What are those things that we're looking for? So as we go along here this afternoon, if you have questions, throw them out. But I want to try to make it interactive. I've got a couple spots where I might have somebody come up and give me a hand. But why are we doing this? We continue to have injuries in the continuing care center and within the entire facility. The CCC has a little higher proportion of the injuries that are related to musculoskeletal injuries, muscle, skeletal, nervous tissue, tendons, those types of things, than the rest of the health system. So we want to try to get to you guys to begin helping you understand what tools we have, when to use them, and how we get that message across. Okay? So why is it important? What is the personal cost to you guys of having an injury? You lose part of your salary, perhaps. You can't work. Financially, that's an impact. You hurt. You can't do the things you need to do or the things you want to do, whether that be hunting or fishing or shopping or playing with the kids or whatever the case may be. And there's a negative impact to that overall. Okay, getting into the comp system can sometimes cause quite a bit of ache and pain in addition to your injury. So we want to think about that. It's not only you though, right? If this gentleman here is injured and you're working with him and he's out of work and you want the weekend off to go to your nephew's wedding and you can't get the weekend off because we have too many staff out, now his injury directly impacts you. It's an inconvenience. It might not cause you pain, but if we're short-staffed, we don't have enough help, we have to pick up that slack, whether that's through overtime or having to work harder on your own shift. So there's a what's in it for me when we look at this. Organizationally, staffing is important, but what do you think a simple muscle strain costs? No surgery, no lost time, maybe restricted time and some medications. What would be the price tag you would put on that the carrier ends up writing checks for in dollars? What would you guess? You have no idea. Simple muscle strain, no surgery. I hurt my back, I hurt my shoulder.
$50.
$50. That's low. Way low.
Way low.
It's closer on the order of about $8,000 or $10,000.
Well, what kind of test did they have? Because this is
I'm just a simple strain. That no workup, no X-rays, no nothing. Okay, I'm talking about a few visits to some therapy or chiropractic or a couple doctor's visits. Okay, but what we forget is that if that person then has to also have all of these other things accounted for, we've got to do an accident investigation. We've got to cross-cover the shift. We've now got to deal with a disgruntled resident, perhaps. All of these things add into that. Okay, carpal tunnel surgery with lost time, it's about $25,000. A rotator cuff tear that probably has between 4 and 6 months of lost time approaches $80,000. And a low back surgery might approach $150,000, right around the time that it happens. If I'm 28 years old and I tear my shoulder up and I don't ever go back to work, that claim will very easily approach $1 million over its life. So those things are the things that organizationally impact us, right? We want to have a place to come back to work tomorrow. So if we're struggling with our comp losses, that impacts our business. That's a negative thing for our business. It's kind of like when your brakes and your hot water tank go in the same week at home, or the same month. That's a bad month, right? Most of us don't have spare cash laying around to handle 2 unexpected expenses, much less 1 unexpected expense. So if we're not planning on having any injuries and we end up with 4 or 5 of them in a month, that has a very negative drain on us. Okay? So the other thing that we're thinking about here is as we talk to people, a lot of times what I'm hearing is that the aides are saying, the nurses are coming to me and asking me how Mrs. Jones should be transferred. Okay? Aides and LPNs by law can't assess mobility. I have no problem with the aide participating in that and maybe rendering an opinion, but it's the nurse's job to determine what somebody's mobility status is. Or maybe it's the therapist, or maybe it's a joint idea there. But we have to have the hierarchy working in the right direction so that the assessment's done appropriately. So I ask a couple quick questions. NIOSH, the National Institute of Occupational Safety and Health, makes some recommendations. Okay? They have an idea of what a safe maximum weight limit for lifting is in healthcare. How many of you think it's A? Just by a show of hands.
20 pounds.
B. C. Most hands go up at C. D. 100 pounds. One there. E. How about F? How many think it's more than that? It's actually B. 35 pounds. Now, how many of you feel like it's D or E? Because we do have that exposure to what we're doing all day long. Okay? NIOSH makes a recommendation. It's not a hard and fast rule. Okay? But there's a lot that we do over the course of our workday and work week that exposes us to more than 35 pounds of lifting, pushing, pulling, those types of things. Okay? But if you're interested in determining what 35 pounds feels like, we've got a basket downstairs in the Pines classroom that we can load up with 35 pounds and you can lift that so you get a sense of what that feels like. Because a lot of times we don't even realize we're exceeding that. And that puts us into harm's way. Okay? So the next question is, if we think about that 35 pounds, which of those patient weight ranges or resident weight ranges does one leg reach 35 pounds? Okay, it's kind of an oddly worded question. But if I weighed 100 pounds in this range C, do you think my one leg weighs 35 pounds? Do you understand the question? So how many of you think it's A, the answer up there? Nobody there. How about B, 40 to 90 pounds? Maybe, a couple waves there. How about C? Wave there. D? E? Wave there. And F? How many of you don't want to answer or don't know? Okay? D. If I've got a resident that weighs between 141 and 190 pounds, there's a really good chance that one leg is going to weigh up to 35 pounds. Or at 35 pounds. Most of you know how much your residents weigh, right? So if you have somebody who can't lift their legs back into bed, or who can't lift their legs to get them onto the footrest alone, and you lift that leg, that's a pretty good idea that you're around 35 pounds. Okay? This was eye-opening to me when I read this research, because I didn't think about it that way. But it's a tool for you to use to begin looking at where you're exposing yourself to workplace stress. Right? We're not going to make it go away, but we have tools for how to do that or to deal with it differently. Okay? So as we start to look at bed mobility, and we look at how we're going to do an assessment, there's a few things that we need to know about. Okay? The first thing is we need to know what the orders for weight bearing are. Okay? If we know that the doc says, yeah, it's okay for the person to be up and moving around, that's the first thing we need. Are they cleared for that? There's no contraindications to weight bearing. What is the past ability of the resident? If they come to us brand new from their home, what is it that brought them here? It might be that their mobility is declining. It might be that they need more supervision than the family can continue to provide. But we also need to know about their ambulation status, their mobility. Was it somebody who went from bed to a bedside commode or a wheelchair? Or was it somebody who could get up and walk 30 feet to the bathroom and back? Or is it somebody who got up and walked outside around the block frequently each week? Because all of those things give us information, right, as we make these decisions. What is their tolerance for activity? Do they tolerate being upright okay? Are there any challenges there? one of the things that we look at, and we don't measure pulse oximetry in the long-term care environment, but one of the things that I've been able to find out is that when we look in acute care settings, if somebody's pulse ox is ranging in this upper 80s, lower 90s region, is where we need to use some concern, because maybe they don't have enough capacity to oxygenate their tissue, and that may lead to fainting. And fainting leads to falling, and falling leads to a healthcare worker lunging out and trying to catch somebody, and then we all end up on the floor. Okay? So we've got to think about those things. So my assessment starts in lying down. And I'm going to be asking the person some questions. I'm assessing cooperation, cognition, combativeness, alertness, anxiety, fear. All of those things come into it. But from a musculoskeletal standpoint, I can have the person simply do a straight leg raise. Can they hold it up? How long can they hold it? What does it look like? Okay? What does this assess? Strength of what? The quads, right? So if I lift up and my knee starts to droop down like this, that's called extensor lag, and that means that I can't lift my leg against gravity. Okay? If I have one leg that goes up like this, and this leg goes up fine, I know that I might have a little weakness on my left leg. If they both do that, now I know that I've got a problem. Right? Because what's going to happen when I stand? My knees may buckle if my quads aren't strong enough to maintain my knees straight. It's really hard to make somebody stay up if they can't keep their legs straight. Okay? The next thing I look at is hip strength, bridging. Call it the bedpan maneuver. Plant the feet, gadget the knees up, and have them lift up. This assesses hip extension strength. The hip extensor is what keeps our waist upright. They're anti-gravity muscles, the muscles that fight against our collapse. So if I bridge up and I have one side that goes up and the other side that hangs down, or they go up and it collapses down because they can't hold it, now I know a little something about their endurance. So if I've got a straight leg raise on the left that looks like this, and a bridge maneuver that looks like this, I know that I've got some left leg weakness. And that's going to help me to make a decision as to whether or not I'm going to be real comfortable getting that person up to standing maybe without something to hang on to or something to assist. Okay? It's being proactive. Too often times we react to that person buckling or losing their balance or keeling over rather than thinking about how we could have prevented that in the first place. So what I'm just trying to do is to give you some real quick assessment things that you can do to try to make sure that our residents are able to tolerate those things. And again, other than O2 stats, we can look at breathing, respirations, anxiety, interactiveness, confusion. Because if we ask people to do these types of things and they become more stressed out, whether it's anxiety or cardiovascularly, then maybe we know that standing is not going to be a good thing for them without some help. Okay? So then we start looking at bed mobility. And I ask the first question is, can the person initiate movement? Are they able to follow those instructions? Give them some time to process the information. Give them some time to process the request. Because some people have been doted on. They come in from home and the family has just been doing everything for them. And they're not used to having to initiate movement to turn, to put a draw sheet underneath them, or to change their bedding. Okay? So we've got to think about that. Are they able, but unwilling or lazy, or unable to do it? And if we don't give them time because we're rushing through our tasks, we don't give them a chance to participate. Okay? So from a standpoint of rolling, if I'm going to ask the person to roll to the right, okay, we have a couple things we can do to make that task easier. You know what they are? Do you use them at all?
Side rails.
Side rails, so they can use an arm to pull over, okay? What we have found in the research is that if I bend the knees up, call it gadgeting the knees, and then have them to start roll, that reduces the amount of strain that I need to use by 40%. Because what happens is the weight of the leg is up in the air, And as I start to get to this tipping point, it pulls me over. It's like a teeter-totter effect. So if I can get them to bend their knees up, or at least one knee, and I might even be able to slide it up myself, that makes this force that I need to pull and to roll them or to push and to roll them 40% less. If they can't tolerate this, we can cross the foot over, have them turn and reach. Those little things can make this task a lot easier, okay? So we want to continue to see how that impacts their need for a chance to catch their breath. How are they feeling with that, okay? So that's another thing that we can do. Moving from lying to side sitting. Now we've gotten them to the roll and they're on their side. Now to come up, if I again let the legs off the side of the bed, it starts to pull me up with the weight of my legs. If I use my arm and I plant or push with my other arm, I can help with coming up as the resident. I get some independence. I can buy into the activity. Okay? That's good for our folks to keep them engaged with that. Okay? If they can't quite push with the arms and come up, and we need to assist with a scoop, we want to make sure we're working with the bed in a good position. We're going to come all the way underneath, capture the back of the shoulder blade, the rib cage, and boost up that way, not pull on the arm. Okay? And think about those things. Keep the bed at a good height for us to work at. Okay? I know we have some challenges with the beds as far as needing to have them go all the way to the floor to reposition them. Then we've got to raise them back up. That takes time. We've got some issues where there's a wall against one side of the bed. We're looking at ways in which we can try to make some of that better. Okay? We're looking at this safe patient moving and handling very globally. But we need your input. Each session today, someone has asked a question or made a point that gives us something to try to make it better. But if we just keep doing what we always do, we always get what we always got, which is a lot of injuries. And we don't want anybody to be the next one. Okay? That's important. Too far away. So we get the person into sitting, preferably with their feet on the floor. And we're now looking at balance in sitting. Okay? If I'm sitting here and I'm flopping over and I'm constantly falling, do you think my balance is going to be any better when I come into standing? It's probably going to be worse. My center of gravity is higher. My base of support is smaller. The distance of my feet versus the surface of my rear-ended thighs. So it's a real good assessment. If somebody is struggling here, chances are they're going to have a harder time when they get all the way up. When we look at upper extremity reach and range of motion, did any of you guys get a chance to use the manual stand aid? It was a white device. It has no sling or battery. We had it here for a little bit. We're in the process of getting some of them. But it's really a rolling grab bar. But the resident needs to be able to reach out with both arms and grab hold of that bar. So if I have somebody who's got a frozen shoulder or a bursitis and they can't reach out, we need to know that because they're not a good candidate for the manual stand aid. They need to be able to pull, so they need some grip. So we want to look at the grip and the range of motion of the hand and wrist. When we get into seating, I like to do some ankle pumps, some gentle kicks, or some marches. Why is that important? What do you think changes when I just get some leg movement going? What's that? Balance is going to be challenged in sitting, so that's going to help me to see how I can react. So that's one thing. What else changes when I do this? Think muscle tone. As I move my legs like this and pump my calves, I contract the calf muscles. That compresses the veins in my legs. The biggest reason people pass out when they haven't been up in a while is there's no muscular activity going on. So when I stand up, these veins are large and wide open, and the blood flow flushes down into the legs, and I go lights out because I've got no blood flow to my brain and my central organs. So this simple activity right here contracts the muscles around the veins, makes them a little bit tighter so that my pressure stays equal. It's really simple to do, okay? But if I've got somebody who's been in bed for 3 or 4 days with bronchitis or pneumonia, and we're getting them up for the first time, that's a great way for us to prevent a fall, being proactive, okay? So we look at how they tolerate that. When we get to standing, again, we're looking at they can get up, what happens next? Can they pick their feet up to be able to pivot? Can they initiate steps? Or do we have that pattern of kind of a shuffling gait that gets going? What happens with that? They may struggle at the beginning of trying to come up because when we're in a chair and our hips are at the level of our knees or slightly below, it's very hard for people to get the forward momentum to get the thighs straight and to get those quads to come on. Our quads are weakest at this bent range. They're strongest in this range. And sometimes you'll see it going down where somebody gets to here and then all of a sudden they fall down and they crash into the chair. Okay? That's an indication that the quads are weak at the end of the range. We've got a whole industry of people who put motors in chairs to raise the seat up. That's because some people need to have that lift. So we've got to think about where are they weak in that motion. When somebody gets to standing, I want to stop and reassess. Are they having any problems with pressure? Are they confused? Are they getting dizzy? So if I stop here, if there's a problem, I can go right back onto the bed or right back into the chair. And I let them kind of stabilize where we're at. How do I check their status? Do I need to take a blood pressure on them in standing? You could, but that's kind of time consuming, right? What's a very easy way to check? You guys got to be thinking about this stuff. How about I talk to them? How about I look at their eyes? If they're getting glassy-eyed or they're shaking their head and they're trying to figure out what's going on, that's an indication that it's not a good idea to take 4 steps away from the surface. Because when they fall 4 steps away from the surface, we're going to be holding them up. That's reactive. We will not stop them from falling. We will end up on top of them or with a strain. Is any of this making sense? I see a lot of glassy eyes out there. I'm a little worried. Okay? If everything's okay, then we start to take a few steps. Okay? Ambulation. We want to stay close. We don't want people far away. Can I borrow you for a quick second, please? Okay? What's your first name?
Wes.
Thank you, Wes. I'm going to have you stand and turn around here. Now, Wes and I are going to ambulate together, right? Is this the pattern that we want to see? No. Why? It hurts their arm. If Wes, is this shoulder okay, or am I going to pop it right outside?
It is right now.
I won't pull any harder than that. If I'm out here and Wes starts falling backwards, this is all I've got, right? Don't go. Okay? If he starts falling in any direction, I don't have anything to hang on to because I'm too far away from him. Okay? So what we like to see people use for standing and basic transfers and ambulation is a gait belt. Okay? A gait belt does not make me superhuman. It does not make Wes ambulate if he's never ambulated before or doesn't ambulate well. Okay? So I like to get the gait belt around the waist. And I'm just going to have you turn and kind of face this way for a quick second. When I hang onto the gait belt, do I want my arm wrapped all the way up in here like this? It's pretty stable. Why don't I want it that way? If he starts to fall, what's going to happen? I'm going to break my arm. I'm going to pull my shoulder out of socket. I'm going to get pulled down on top of him. So we want the grip where I've just got a handhold back here. It gives me some control of where he's going. Turn this way again for me, please. Now, as I walk, I like to hang on to a hand here or an arm. I've seen some people who will grab the gait belt on either side. Okay? But until I get a sense for how he's going to do, I'm going to be a little closer to him than he's probably comfortable with. But I'm just going to explain until I know how you're not going to fall over. I'm going to be tighter with you, and I'll give you a little bit more leeway. Okay? So now if I come out here and we're doing all right, I'm going to have you just take a couple steps. what I do is I square up to him, and I'm kind of watching what's going on, and my base of support, the distance between my feet, is his landing zone for walking. So if he does start to fall back, I can pull him in, hold close, get me a chair, I need a chair, help me. Okay? Wes, are you with me? I'm looking at his eyes, I'm talking with him. Too often times I see our staff dragging poor Mr. Jones down the hallway, and they're talking about what's going on in their life, not paying attention to what's happening here. Okay? And we've got to make sure that we're in tune to what's going on. That's how we're going to prevent what we call a miss, or a near miss, or an actual accident. Okay? I need to be in tune to what's going on. So as we're going along here, if he starts to get out, we're halfway between our two surfaces, I don't have a good bailout spot, and he's going to go down. What we used to teach was try to let him sit on your knee or slide him down the leg, right? I'm the same size as Wes. How successful am I going to be with that? Probably not very. And what we're training now through the Safe Patient Moving and Handling Conference that was last October in Albany, we lower until I can no longer keep my back straight and maintain, and then I let go. I guard the head and I try to soften the fall. That is not in our makeup usually as a healthcare provider. We've got to overcome that because I cannot stop him from falling safely. It will not happen. But that's why we've got to think about setting things up and being proactive as we go through it. Okay? Thank you very much. Any questions about anything with ambulation? The gait belt, again, is just a real good spot for contact. Okay? Once they're on the floor, how do we get them up? We use a bed sheet and 5 or 6 staff? No. Okay? The lift slings that we have are weight rated for 1,000 pounds. Whether it's a small, a medium, a large, a 2XL, or whatever the case may be. Okay? What is the weight rating on a cotton sheet? It doesn't have one because it's not a lifting device. And I found that out back in 1999 or 2000 as a lady was being lifted up on the 3rd floor with 6 staff, and the sheet ripped out when she was about 6 inches off the ground. And the 3 people who were on the side of the sheet that ripped out went flying up in the air, and the 3 people who were on the side of the sheet that didn't get ripped out got pulled back down to the floor with the patient. We were fortunate. We scared the poor lady to death. We scared the staff, but nobody got hurt. But a sheet is not a lifting tool. I don't care if it's 600 thread count fine Egyptian silk. It does not get used for lifting. Okay? Nor do bath blankets or blankets. We have lifts for a reason because we're not human cranes and we need to be safe about that. So, all of this stuff does require a little bit more time. We need to assess. But think about that rotator cuff tear. That cuff tear is probably going to take 20 to 27 weeks, 28 weeks to get healed up all the way. It does not take me that long to get a slip sheet, to get the right equipment. It's an inconvenience at that moment, but it's a lot less inconvenient than filling out the accident report and going to the ED and having an MRI and then having surgery and therapy. Okay? Think about going home in the condition that you got here in. You probably are all aware of a healthcare provider, nurse, LPN, CNA, who no longer works in healthcare because of a career-ending injury that occurred in work. Okay? I know several from here at Thompson in the 12 or 15 years I've been involved. Okay? How many of you have seen the Patran anti-friction sheet? By a show of hands. 1, 2, 3, 4, 5 have seen it. How many of you use it? 1 or 2. How many of you use it regularly, every day, several times a day? That to me is opportunity. That's why we're doing this. We need to increase the awareness of the tools that we have available. What do you think this costs? What would you guess? $2? You're right on. $1.80. Okay, unfortunately, I don't. You can have another cookie. How many of these can we buy for that $80,000 rotating hip repair? Cases and cases and cases of them. Okay, it is really a plastic bag with both ends cut out. It's a tube. It's got a little treatment on it to make it slide. It's designed to be used in a single patient environment. It's not designed to go from room to room or bed to bed. It gets set in Mrs. Jones's care plan, and we use it that way, and it stays in her room. We're done positioning her. We can fold it up, and we can put it in the room somewhere. Okay? What's good about that? If it's where we need it, are we more likely to use it? Absolutely, right? So they're inexpensive. We can put them where we need them. They will decrease the force required to reposition somebody in bed by, again, 30 to 40%. So we know that a 200-pound person requires each caregiver on either side of the bed about 100 pounds of force to pull somebody up. If I can reduce that down to 60 or 65 pounds of force, does that sound like a better opportunity? Okay? But if we don't get them out of the box and into use, they don't provide that assistance. Okay? We've got to use these tools that we have available.
I think the evidence to use that has been amazed.
Right.
How it's like in their workflow.
So again, we're part of the, I'm not waggling fingers if you haven't used it or don't use it. I'm trying to get a sense. I got to get a pulse of where we're using them, where we're not using them. And if you aren't using them, you need to go back and say, who on my avenue do I struggle with to get repositioned in bed or to get moved around? They're very simple to use. I will come show you how to use them. I've been in servicing. I've been trying to get the message out there. We have safe patient moving and handling champions on pretty much every avenue now. People have gone through an extended level of training. They are our resources. If you don't know who they are, ask. And find them and ask them to help you if you've got a difficult resident or a difficult situation. Okay? We need to look at the resident's weight and their level of assistance. If I have a 300-pound resident who is able to roll, able to sit up, able to stand, and able to get out of bed, I do not need a slip sheet. But if I have somebody who weighs 120 pounds, who's contracted and non-cooperative and difficult to move, that may be the jackpot right there. Because if this makes it easier for us by decreasing drag, what else do you think it does for the resident? If I decrease drag, what am I doing for the resident? Exactly. I'm not tearing up their rear end. I'm not breaking their skin down. I'm not causing a decubitus ulcer that now requires more care, more turning, more effort on our part, more discomfort for the resident. So it's not only safe patient moving and handling, safe resident moving and handling for us as the caregiver, this is good care for our residents. That's what we strive for, right? We want to take care of our residents. We want to go home whole. So we've got to think about those opportunities. Just because I put a slip sheet under somebody doesn't mean it automatically goes to only assisting with one person. It still will most likely require 2 caregivers or 3 caregivers or sometimes 4 or 5 caregivers if I'm doing a lateral transfer from a stretcher into the bed or the bed into the stretcher. Okay? We can show you a lot of tricks with these. They're great for boosting and lateral transfers, and if you have a very large resident, 250, 300 pounds, who is not able to help you, and you're trying to go from the bed to a stretcher, I can take one of these sheets and get it underneath the resident. I can put another sheet on the receiving surface, and now, instead of me reaching over and trying to pull on this side of the stretcher, the caregivers on this side of the bed send the person segmentally. What I mean by that is shoulders go 6 or 8 inches, waist, hips go 6 or 8 inches, legs go 6 or 8 inches. That might have us halfway. If not, We cycle back through again. Now, the person has moved from here to here. We bridge the gap maybe with a transfer board, a slide board, so that we've got a nice little cover there. Or we simply take the receiving surface and lower it down an inch or two, which is standard procedure. And now I can reach out and grab the draw sheet and I weight shift back. I don't have to get up here and lean back. I grab hold of my draw sheet and I weight shift back. And I weight shift maybe at the shoulders, and I weight shift at the hips, and I weight shift at the feet. And instead of trying to make it one big fell motion, we do that segmentally. Does it take a little bit more time? Yeah, it probably takes a little bit more time, but it's a fraction of the time of an injury. And that's what I'm trying to get you to think, okay? I've asked the question in each class. In nursing school, did any of you take a class that said, check your well-being at the door at the time clock and do whatever you must do to care for your patients or residents? Did you have a class in nursing school that taught you that? I know we didn't in physical therapy, but the mindset of healthcare workers is, I'm going to put myself in my own expense under the wheels of the bus to take care of that resident. But if I do that, I'm not much good tomorrow or next week. So we've got to think about being able to come back again tomorrow. So how do we get the Patriot sheet into position? Okay, Wes, could I ask you to help me again one more time? I don't want you to, get stiff there, sitting for too long. So the easiest way to do this, okay, is for me to work. Now this would be low for us. We want to raise it up, but we don't have an adjustable height conference room table. So we're going to kind of demo this. Sometimes people will say, it's better for me to reach over and pull. Some people talk about pushing. We've talked both over the years. What came out recently at the conference was if Wes takes his side of the draw sheet and he bunches it up and he just comfortably hands it to me. So roll your sheet up. Think about a resident kind of being here in the middle. And you just lift that up. And maybe if we can't bunch it, maybe in order for me to reach, we do have to unfold it. It all depends on how far we can get. But instead of me reaching over and pulling, if Wes hands it to me here, my feet are staggered one in front of the other. I'm not standing with my feet together. And what am I going to do? Am I going to pull with my spine real hard? No. What I'm going to do is I am going to rock back. I lean back onto my back foot and I turn that resident a third or at most a half a turn. Right? And then what Wes does is he opens up the sheet. I'm holding the resident, and he just takes it, and he can get his hand up into a fold of this, and he tucks it in, and he tucks and he tucks and he tucks until we've got about half of the sheet bunched up under the resident while I'm still holding. Now, I slowly rock back, let the resident down. I hand the draw sheet to Wes. He grabs hold, and now he rocks back. And I take the draw sheet and I flatten it out. And then we lower the resident down. Okay? And we come back. Now, we want to boost them up to the head of the bed. Too oftentimes what I still see is people bending forward and rotating and twisting. Okay? What you want to do is you want to get your feet pointing in the direction of your transfer. Think about when you walk with somebody in a stretcher. You don't walk down the hall like this, right? Facing the stretcher. What we do is we turn our bodies and we kind of walk normally with our rotation of our trunk. So if I can rotate my trunk and Wes comes in and rotates his trunk, now what we want to do is grab hold of the draw sheet and we want to shift our weight from the foot side of the bed to the head side of the bed if we're boosting them up in bed. Okay? Now, do I want to grab the draw sheet with my palms down or my palms up? Do you think? And why? Down? I see nodding. Do you know why? What am I more likely to do if I grip with my palms up?
Use your arm strength.
Use my arm strength and also lift them off of the draw sheet. or lift them off of the slip sheet. And I want them to be on the sheet. Otherwise, it doesn't do any friction, and I'm still working hard. So if Wes and I get in here, and you're going to kind of bunch this up right next to their trunk, we're going to keep the load in so you can even get in a little tighter. And on 3, 1, 2, 3, we drive up. Now we take Mr. or Mrs. Jones and we reposition them in bed. Now, if Wes and I aren't used to using this sheet, it's the first time, we've got to be real careful that we don't put Mr. Jones's head through the drywall, because this is slippery. Okay? So I generally take a pillow and I put it up against the head of the bed, and I get a sense for how much easier that's going to be, because they will slide very easily. Okay? Now, that which helps them go up, if we don't take it out, will help them slide back down, right? So we've got to get it out. You can roll the patient back and forth, or the resident back and forth if you need to, but what's easier is if I reach up under the shoulders of the resident, I grab a handful of the sheet under their shoulders, and I fold this under itself. Just kind of hold that down. And all I do is I grab hold and I walk back towards the resident's ankles. And it will come right out with next to no effort in a split second. And if you don't believe me, we can do a quick demo, but we'll do that at the end. Okay? They come out very easily. 40% reduction in friction forces for all of us. Good for the resident, good for us. Thank you again. Okay? Any questions about these? They are a very inexpensive lifesaver for us as caregivers and a skin saver for our residents. Okay? If you guys are dying out there, stand up, please. Stretch, move, get some oxygen in your system.
So how many people does it take to move with that sheet?
Well, generally it's going to still be a minimum of 2, okay? Because you're going to need a caregiver on each side. We do a demo when we do the training where we get the sheet underneath somebody, and if the resident can tolerate a Trendelenburg position, that even makes it easier. Sometimes they start sliding before I even put my hands on the draw sheet, because we've reduced the friction, and they slide up in bed, and then you just flatten the surface back out again and get them upright. But there's nothing in our care plan or in our policy that says that because we put the slip sheet in underneath, I say, hey Wes, good luck, I'm out of here. I still need to work with him. We still need to work together to reposition the resident. Okay?
Now I know Lakeview and Meadows have those available. How about the other avenues?
I think we do have some one other place.
I've
We
seen
have
them
one
down there.
disabled use and someone that doesn't
Someone
use
else, yeah.
So all I'm doing in today's presentation is trying to make you aware that we've got some really cool stuff in our health system to make you guys have to work just a little less hard. Our jobs are hard enough, physically, mentally, emotionally, that we need breaks where we can get them. Okay? And if it makes the care better, it makes us happier. Okay?
Or do we just throw those away when we're done using it with that patient?
What happens is that they're good for about 20 to 30 uses. When you're not getting good slipping anymore is when they do need to be replaced. Okay? The manufacturer tells us that they're fully recyclable. I don't know how robust our recycling program is to know what to do with them. I think that's going to potentially be a challenge for us coming up. They are designed to be discarded. They're not designed to be laundered. Okay? And they are not designed to go from my room to Wes's room to your room. Okay? They stay right there. Okay? But if you've got somebody who you think might be a good candidate with it and you're not sure, and it's a Tuesday, call over to Associate Health and say, I need that Patran guy to stop over, that slip sheet guy, if you don't remember Kurt. Okay? Pete Gordon's in the back of the room, the director of rehab. He is also a resource. He knows more about this stuff probably than I'll ever dream of knowing. Okay? Cooper, down in rehab services in the Pines Wing. He knows it. He came to the session at 7 o'clock this morning. Okay? We're trying to get everybody on the same page so that we can stop hurting you.
Do you know where we get those?
They're ordered through central stores. We have them on part order here in the house. Usually a case or two. 25 to come to a case, With shipping, they're about $60 for a case of 25. Okay? I won't even ask you to write a check for it, though. We'll just get it for you. Okay? They do make life a lot easier, and the people who have used them, like Kathy and Jean Ann indicated, like them. They help us. Okay? The manual Stand-Aid, this is a really lousy, grainy picture, but for those of you who didn't see it, it's got a narrow base on it with a foot plate, wheels, shin troughs, and then these pads up here rotate out left and right, independent of each other. One goes one way, one goes the other way. So you open those pads up, you wheel this in front of your resident. If they can, they lift their feet up onto that plate. If not, I might have to lift their feet up for them. Again, this could be one caregiver, it could be two caregivers, depending on our assessment. We lock the wheels on this model because this is a stand grab bar, really. It needs to be permanently placed. We don't want it rolling as that person's pulling up on it. Okay? How many of you have had a resident in the past that wants to reach up and wrap their arms around your neck and shoulders to pull themselves up with, right? That's a technique I used in a developmental center in 1980-something. We'd wrap them around us and I would try to stand up. And we were human cranes. And how we're all not crippled today, I don't know. But what happens is when the person stands up, they're hanging onto this bar here, they reach out and grab hold of it. That's why we talk about upper extremity range of motion and grip in our assessment in sitting. And they pull themselves up instead of pulling on me. If they can't initiate that early part of the movement, we can put a gait belt around their waist. The caregiver would be on the outside here. They can reach in underneath that gate or underneath that bar, get a hold of the gait belt, and can rock back to assist that person with getting the butt moving forward. Okay? We get them up onto the platform. We pivot these paddles back in behind their butt. And if they can't tolerate or have enough endurance to stay standing, they can sit on that. The shin pads block forward movement of the legs. The butt pads hold them. And this is a great way to get that person to a commode chair, to the toilet, to a shower chair. The person who can stand but can't do this. And too often what we do is we stand them up and we force their legs this way while their toes are still facing this way and try to drop them into the chair. And we can get spiral fractures of the tibia, the shins, we can tear up the knee cartilage this way, and we can cause a lot of problems for them. Not to mention falling, where then we try to stop them. So this works very well. It is narrow enough to essentially fit between the legs of that chair. So it will fit between the wheels, the front wheels of the wheelchair, yet it's wide enough to go around the base of the toilet, which is pretty slick. And it's narrow enough to fit through the doorways in the bathroom. It's weight rated for about 400 to 450 pounds, depending on the model that you get. But you need to have somebody who can bear weight in both legs, who can follow some instructions, and who has the ability to pull. What's really cool about it, no power, no battery, no soft goods slings and those things. So when I have my Stand-Aid, I've got everything I need. Okay? They work very well. We've kind of gone over the indications. Okay? Did we order some of those?
I think we still have the original one on site, and we purchased 2 more.
Okay.
They should be here soon.
So as they come in and somebody says, oh wow, that's that thing that was in that slide presentation, I don't really know how to use it, what do? Do you push it into the storeroom with the other stuff that we don't use? Or do we say, wow, call Kurt, call Pete, call Jean Ann, call Kathy, call somebody and we will come. Okay? It takes about 15 minutes to give you the rundown on it.
We didn't order one for Gardens or Rosewood because there was concern that maybe the residents couldn't follow directions. But if you're on those avenues and you have someone that you think would benefit, I'm sure we could borrow one and try it out.
Let us know.
They're inexpensive enough so that it's not, we could purchase one easily.
To give you an idea, we can get about 3 or 3.5 manual Stand-Aids for one powered sit stand. Okay? So we do have the ability to get that, and I
One
think...
thing that has come up with the stand-aids, and I think it's a training issue, is that if you're going to move them away from, you get them out of the chair, and you guys can jump in because I'm not the expert, but if you get them up out of the chair, don't move them away from the chair until you put those seat things down, because some of them can't support their weight for a long period of time. This way they can rest a little, and then when you go to get them up again.
Yeah, it is not a transport device in
Right.
stand. They must be sitting before you transport them.
Before you move them. And that's for stability too, so we don't have tipping and those types of things. And you have to unlock the brakes on the wheels after they get up, or it won't wheel. So you've got to just, with your foot, click those brakes off so that you can move them. Okay? So that's manual stand aid. The next one, the sit-stand power lift. You're familiar with this. This happens to be our Medcare model. It's what we're pretty much going with most of the time now. It's got the foot plate and the base on wheels. It's got the lifting yoke. You've got the calf or the shin pads here. This strap here is on all the models, but it is optional. You may have some residents that you need to lock their legs in if they pull up the leg or they're unpredictable, or you just want that extra stability. But we can use this without that strap. The harness or the belt that we use goes around the waist at the iliac crest, that bony ridge. It does not go into the armpits. You don't want to be taking that sling up and putting it up into the armpits. We've had a couple issues where people have had some bruising, some soft tissue damage up in that area. And the other thing with this is, can you see how this gentleman is not standing upright in this, right? He's kind of hanging back. We only need to lift as high as we need to clear the rear end off the surface. The higher you bring that yoke up, the more likely the sling is, the belt is, to ride up into the armpits. And that's where we can get into some trouble. So some people will pull themselves up and they may stand on it, hanging onto the handrails like this, which is fine, but we've got to make sure that we've got the belt around the waist, and there's a plastic clip in the front, a buckle, that must be buckled. If you choose not to buckle it, you're not connecting the resident to the lift. You're violating our policy and how the lift is used. So we've got to make sure that that buckle is buckled and the strap is snug down. As we come up, they get weight bearing, and now we can roll and move them around again. So the resident must be able to bear weight. We want them to have fair sitting balance. Why? Because we've got to be able to get the belt around them. If I get them to sitting and they start flopping over, it's really difficult for me to get the belt positioned properly. So I want them to be upright. If they have really lousy sitting balance, but this is a good way to stand them up and we assess that, how can we counterbalance that? We bring in a second caregiver to help stabilize the trunk balance in sitting while I get the belt on. There's nothing that says that this sit-stand lift only should be a one staff lift, a one associate lift. Oftentimes we will still have two caregivers for this lift. Okay? It's depending on the assessment. Nursing, PT, OT, we're putting our heads together as we look at this. But there's liable to be somebody who comes in here on a weekend that you may need to assess to determine mobility. And what we're trying to do is to give you some skills for when somebody is coming in new and we need to determine what their status is, or someone is coming back to us from some alternate level of care and we need to be sure that they're okay. Or they're sundowning, or they've got a little touch of bronchitis or pneumonia and it's wiping them out earlier in the day than they might normally. And we've got to determine, is it still safe? We want the person to be able to follow some directions. They don't necessarily have to remember those directions day to day. We have a fair high number of people who might be able to follow those instructions, but 3 hours later they don't recall doing that activity. But if we explain it to them again, they can be fine with that. That's acceptable. Okay? The person may be able to stand, but again, if they don't have the ability to lift their feet to pivot, this is another way that we can do that. Because we may not have that manual stand aid in all areas. If they have poor endurance in standing or poor arm strength and they can't pull up or they can't use that manual stand aid, this helps. The belt goes snugly at the waist as we've talked about. Okay? Any other questions or points that you guys want to make about the sit-stand lift? I think it takes a lot less time to get the belt on people than it does a total lift with a sling underneath people. But you've got to make sure that you meet these criteria or we're going to be using the wrong piece of equipment. And then the total lift, again, this is our Medcare version. We no longer have the chains that we used to have on the Hoyer lifts of old that inevitably pinched somebody or cut them or had problems. So anything that's near the patient is padded with foam, it's soft fabric material. We can get this hooked up to the sling and we can go. Again, you've got your base, the spreader, the battery, the lift arm. Most of us in the CCC are pretty familiar with this. Okay? So when we look at, again, our indications for this, the resident is unable to bear weight. They may have very poor sitting balance where they can't come up and be upright at all. They might be real floppy or low tone. They might be confused or unable to follow instructions. Okay? This is our highest level of assistance. They really can't do much at all for themselves. Think about that 35-pound limit that we talked about. Again, it's a guideline. It's out there for us to be aware of. But when you're struggling more than that, let's come up with an alternate way. And then this last point here, somebody who is on the floor, resident, patient, family member, visitor, I would really love for us, whenever we have someone on the floor, that we assess them. If they do not have the ability to get up and pull themselves up on a chair or something stable, I don't want us being the person who says, well, just hang on to me and I'll bring you up, or pull yourself up on me. I want to have them get up with a lift. Once they're on the floor, they can't fall any further. We assess them, we make sure they're safe to move, we reassure them, we get the sling and the proper number of staff, and we can raise them up. That should really be your first thought, is where's the lift when we've got to get somebody off the floor. And that's whether they've fallen on a bed, or they've fallen in the bathroom, or we've had to lower them to the floor during ambulation. Okay? I'd like it to be if it's the lobby and somebody wipes out on a wet floor and falls and breaks a hip. We can use the lift if we know what we're doing. In some situations, if it's a scoop and run, we may be backboarding, but we've got to look at those situations. Okay? There are extenuating circumstances where we're going to evaluate that. Other things to just be aware of, sling selection. The slings come in multiple sizes: small, medium, large, extra large, and 2XL. They are notated on the back by a color handle: yellow, white, blue, purple. Those colors equate to a little sticker that's on the side of the lift that will tell you what size it is and what weight range is in there. Okay? So I think a medium sling says 100 to 210, but a large says 200 to 310. So if I've got somebody who maybe is 200 pounds, but all the weight is in here, we might need the width of the large sling, even though it might indicate a medium is a good size. You want at least 3, if not 5 finger, a whole hand's width of fabric on either side of their trunk as you go to raise them up. Think about what activity we're doing. Are we bathing? Are we toileting? Are we going to a commode chair? Where do we need to position the sling? The legs, the straps. Do we need a bathing sling? Do we need a hemi sling? Do we need a amputee sling? They're all out there, and we need to think about those things. Okay? Cleaning, the lift should be cleaned every time they leave a room. Slings can be wiped off with a cavi wipe if they're spot soiled. If they're really a mess, we need to send them to laundry. We also have single patient use disposable slings. They're a white cloth material. They work very well when we've got somebody who might not normally use a sling, who maybe comes back to us, and we can't use our normal transferring status for a few days or weeks, or if somebody's on contact precautions, or they've got something that we don't want to be moving around. We have the ability to get those things. Okay? Do you guys have any questions or points, or Pete, or Jean Ann, or Kathy, you want to add anything? You guys are our resident experts, really, in safe patient moving and handling because you're exposed to it. We have some tools that can make your job a little bit easier, but if you don't use them, they don't help you. Okay?
And you're the ones that are out there working hand in hand with the CNAs. So you're the ones that really are going to see some of the things that are like, ooh, wait a minute, let's get the patron sheet. You know what? Maybe they need to be a 2 assist now with that. And you can add those things and then put in, let the nurse managers know, let the assistant nurse managers know so we can get them reassessed. Because you're the ones out there and you're the ones that are going to see it.
Don't take shortcuts when it comes to this, because as Kurt said, one quick injury can impact the rest of your career. So it's really not something you want to take the risk in. The other thing I have seen recently, I just need to say, never is it acceptable for one person to move somebody up in the bed by themselves, because you're just asking for an injury. Back when I first graduated, we did that all the time. And a lot of people that I know are no longer practicing because of catastrophic back injuries.
Once you start using a slip sheet, you'll be surprised how many residents who you thought couldn't move. You ever ask a resident, push yourself up in bed, push with your feet, grab your arms, right? Push up, and they're like, they're stuck to the cotton sheet. They're not going anywhere. You start using a slip sheet, get it underneath the draw sheet, right? Bend the patient or resident's knees up because there's no friction. They can actually push themselves up. So you may not need 2 people to have someone slide up in bed if the resident can do it themselves. I've seen that 1,000 times. The resident's like, oh, I can do it myself. If the resident can do it themselves, just like I heard Kurt say, let them. Please let them. The other thing I wanted to bring up, the total lift, those slings, are those the horseshoe shaped?
Yeah.
Mm-hmm.
Anyone ever put someone in a chair early without a sling? And now they're tired, they don't want to get up, you have to put them back in bed. And the old style slings, what do? Oh, we forgot to put a sling underneath them, so guess we got to lift them up, right? Well, those new horseshoe shaped slings, tell me if you guys know this already, you can install it in sitting. Years ago, it used to be a big hammock style, so you have to lift them up to get a sling underneath them to lift them up, right? Didn't make sense, did it? These horseshoe shaped, you have them lean forward, get it installed behind them, wrap under the leg, and you can install and lift. Did you guys know that? Some people are like, yeah, some people are like, yeah, really? It's so easy to install.
And the other point that Sharon Hafley made at the end of the last one, I didn't really talk much at all about repositioning in a chair, a Jerry chair or wheelchair. We don't want you tugging and pulling. We can use the lift. You can, just as Pete's explaining, you take that down and you just get it to the top of the surface that they're sitting on, and then you can raise them up and just boost them back. So we've got to look at other ways. If you're struggling, we can use these Patran sheets to help with repositioning and sitting. Any place where we're fighting friction or overcoming a drag, this will help. And sometimes we're only limited by our creativity of how to do that.
I want to try them crumpled up in the bathroom when you have that resident that's on the floor. Put them under with the draw sheet. You can pull that resident out from the corner far enough that you can get the lift in there, because lots of times that's our hardest thing, is being able to get that full lift in place when they are fallen in a tight corner. But if we can get those Patron sheets and a draw sheet under them so we can slide them to where we can get the lift under them, would be great.
Do you teach the installation without pulling or touching the patient?
I did today.
Yeah, that's a lot of work.
We do that more when we do safe patient moving and handling training. What Pete's saying is that you can take the sheet and you can fan fold it. So I shape it out like this, and I just fold it back and forth. And then when the resident is on the bed, everybody's got a little hollow behind their low back, we take this and I put my hand right in it, and you shove that underneath that point, and then we can unfold this underneath them. It does take a little bit of jockeying back and forth, but if you've got someone who has a compression fracture in their low spine or something like that, we can get it to go underneath them without rolling.
Do it like this. Put underneath.
Or yeah, you can do it that way too.
And hold it right underneath
Yep. These guys showed us the low back method, and half goes up and half goes down. This one's kind of worn.
it. Yeah.
Again, I didn't have a good picture. I was going to put it in, but then I thought that if you hear what it sounds like and you know what it does, you're more likely to try to find it. Okay? But
So
we're
we've,
available.
We've put a lot of money into lifting equipment here in Thompson. I think we're better off than a lot of facilities, but it's up to you guys to use it. And it really takes the whole team. So if you see anybody doing anything that you don't feel appropriate, please bring it to their attention.